Takizawa from Kanagawa Cancer Center, Yokohama. Thank you very much for great opportunity for me to talk here. And I also appreciate for the Olympus company for support every day. Thank you very much. So today in lecture symposium, I would like to talk about complications in the upper GI tract. So first, I will talk about a little about gastric ESD in our daily clinical practice in Japan. So first, we perform marking using magnifying endoscopy, such as XD 1200 or EZ 1500 in Japan. So after that, we switch to a therapeutic scope, the H290T scope in Japan, or probably the H190T scope in Vietnam here. The therapeutic scope has a wider downward angulation range, which makes the procedure easier. So these are the main devices I currently use. So I use the IT Nano knife for the esophagus, IT2 knife for the stomach, and the dual knife for the colon and duodenum. Regarding hemostatic forceps, I use a coagulosper G for the stomach and a standard coagulosper for other organs. ESD 300 from Olympus and the Bio 3 from AVI are the most commonly used in Japan. I'd like to show the schedule during hospitalization for ESD. The patient is admitted and undergoes ESD on the same day. On the next day, the patient has a second look endoscopy to check the reading or delayed perforation, and X-ray and blood test. If there are no problem, drinking is resumed. 2 days after ESD, the patient starts eating, and the patient is discharged 6 days after ESD. Like this. So next topic is today's main topic, the management of complications. As you know, the major complications of gastric ESD are delayed breathing and perforation. In large-scale Japanese ESD data, among over 10,000 ESD cases, the rate of post-operative breathing was 4%, and intraoperative perforation rate was 2%. So first I will talk about delayed breathing. So previously we reported to prevent delayed breathing, hemostasis of any vessels that appear on the ulcer is essential. We call TEC. Any visible vessels on the ESD ulcers should be coagulated using hot biopsy forceps. This TEC and oral intake of a PPI are effective to prevent delayed breathing. I'd like to talk about recent issues. As the use of antithrombotic therapy has increased, the management of these drugs during perioperative period remains a matter of great concern. In this report from Japan, the rate of delayed breathing in all patients was 5%, but with antithrombotic agent, the breathing rate was increased as 14%. Recently, clinically useful prediction model, test J-score, for breathing after ESD for EGC was reported. The scores of selected predictors were assigned as follows: 4-point warfarin DOAC, 3-point hemodialysis, 2 point aspirin, chenopyridine, 1 point silostazole, margin tumor, over 3 centimeter, and the lower location. The rate of bleeding after ESD was at low risk, 0 to 1 point, bleeding rate only less than 3%. However, the score 5 points or more, it's a very high risk. The risk of the bleeding rate approximately 30%. So PET and PPI intake seemed not enough to prevent delayed bleeding for such high-risk patients. Therefore, a new effective method to prevent post-ESD bleeding for such high-risk patients is desired. So there are two methods to prevent delayed bleeding, sealing and closure. Today, due to time limitations, I will talk about closure. In Japan, closure after ESD is a very hot topic, and various methods have been reported. These methods are using end clips. And OTSC is also one of the devices choice. And some methods similar to surgical suturing have also been reported. So I will introduce end loop closure, so one of the closure techniques. In this method, we use an Olympus detachable snare and end clips to achieve complete closure of the post-ESD survey. I would like to show the video. So after prophylactic coagulation of the mucosal defect, end loop was opened and the end clips was prepared through the channel. So we put the end clip onto the end loop and use it to anchor the end loop. Several additional end clips were then used to fix the end loop around the edge of the mucosal defect, like this. After fix of the end loop to the ulcer edge like this, so mucosal defect was successfully closed by tightening the fixed end loop like this.
Mình làm nó mới khó.
So this was a retrospective study we conducted in the past. So end loop closure was performed after gastric ESD in patients taking antithrombotic drugs. The complete closure rate was 67%, and delayed bleeding occurred in 7.8%. But among patients with complete closure, the delayed bleeding rate was only 3%, with just one case. So now I will introduce about the recent trends in Japan. So recently, roll and origami technique have been attracting attention, and I also find the ELOC very interesting. First, I will introduce the ELOC. This method uses the ligation device for EVL. The nylon loop is fixed with clips, then loop is then pulled, drawing the clips into the cap like this, and overland for EVL is deployed to ligate the clips. The key point of this method is to place an additional clip in the center of the ulcer bed here to eliminate the dead space. In this way, complete closure of the ulcer is achieved. Sorry, let me show the video. First, nylon loop is fixed to the ulcer margin with clips. The nylon is then pulled and drawn into the ligation device like this, where the clips are ligated with an overland like this. A clip is also placed in the center of the ulcer bed after that, here, like this. In this way, the complete closure is achieved. Very tight. After several ligation, this, so complete closure was achieved. Next, I will introduce lorem technique, since it has already become a very popular in Japan and other countries. So many of you may be familiar with it. So in the lorem method, multiple clips are passed through a single line and alternately attach it to both sides of the ulcer margin to achieve closure, like this. So I'm sorry, today I have no much time, so I skipped the video. So if you are interested, so please refer to the article. Like this. It's a lorem technique, like this. So I will show the result of a study conducted to evaluate the usefulness of lorem. This retrospective study compared the high-risk patient for delayed breathing. The delayed breathing related rate decreased from 7.7% to 1.8% with lorem compared to the non-closure group. So in conclusion of their study, so lorem is feasible and may effectively prevent post-ESD breathing. But it is only a retrospective study, so the prospective large-scale study is necessary. The origami method was developed by a Keio University group for closure of the duodenum ESD. The main feature is holding the muscle layer with clips in this way. So origami has also been reported for use in the stomach, like this. But in my opinion, so the stomach wall muscle layer is a little bit tough, stiff than the duodenum region, so it is a little bit difficult in the gastric region than the duodenum region, but it's possible. So I will also briefly mention about the suturing. So overseas, especially United States, so many closure are performing using like an overstitch, but unfortunately it cannot be used in Japan. So in Japan, endoscopic hand suturing device called Stuart is available. So I heard here in Vietnam also it's available. So I will show the result of a multi-center phase 2 trial. So the study included the lesion 2 centimeter or smaller in patients taking anthelmintic drugs. Here are the results. The completion rate was 100%. The average suturing time was 48 minutes. The closure was maintained in 83% after 3 days after ESD. The delayed breathing rate was 7%. So endoscopic hand suturing may prevent post-operative breathing. So today I showed several methods to closure, but so is closure actually useful for preventing delayed breathing? The answer is no. No clear evidence